Welcome to the deep dive. Today we're tackling brain pathophysiology, specifically Porth's chapter 16.
Yeah, it's dense stuff.
It really is. Our mission is to kind of cut through that textbook language and give you a clear, actionable summary.
Connect the dots, basically.
Exactly. Link those deep mechanisms, the why, directly to the clinical signs, what you actually see at the bedside. Hopefully make learning faster.
It's crucial because the brain, well, it's a bit of a paradox, isn't it?
How so?
It's incredibly well protected. You've got the skull, the CSF cushion, that super selective blood-brain barrier.
Right. Fort Knox up there.
Pretty much. But despite all that, it's still so vulnerable to trauma, ischemia, tumors, metabolic shifts, all sorts of things.
And the injuries, they often funnel down similar pathways leading to predictable problems.
That's the key. Predictable, destructive pathways.
Okay, so let's start where trouble often shows up first. An altered level of consciousness, LOC.
Right.
Before we talk about decline, we need to define consciousness itself. It's not just one thing, is it? It's like two components.
Absolutely. Two critical parts. First, you need arousal or wakefulness.
Okay.
That's driven by the reticular activating system, the RAS, down the brainstem. And, importantly, it needs both cerebral hemispheres working, too.
Both hemispheres and the RAS. Got it. What's the second part?
That's the content or cognition. Think higher functions, awareness, processing. That's the job of the cerebral cortex.
So if I have, say, a small stroke just affecting one part of the cortex, a focal injury.
Right.
My consciousness might be totally fine. Maybe I lose arm movement, but I'm still awake and aware.
Typically, yes. Because the other hemisphere is compensating and the RAS is usually untouched.
But if the injury hits both hemispheres, like a global lack of oxygen, or if it damages that RAS.
That's when you see altered LOC. That's the trigger for starting down their whole spectrum of decline.
And it is a spectrum, right? A continuum.
Definitely. You need to picture it stepwise. You start fully conscious, then maybe confusion sets in.
Okay.
Then lethargy. The person's sluggish, sleepy, but still rousable.
It gets worse.
Yes. Obtundation. Now you need vigorous, maybe even painful stimuli to get any response.
Wow.
After that comes stupor, and finally coma. No purposeful response.
How we track this objectively? There's a tool for that.
The Glasgow Coma Scale, the GCS, it's the standard bedside tool.
Right, I've heard of that. It scores different responses.
Yep. Eye-opening, verbal response, and motor response. Add them up, you get a score between 3, which is deep coma or death, and 15, fully awake.
What's the real value of that score day to day for the nurse or doctor?
Oh, it's huge. It gives you a baseline, an objective number. Someone's a GCS 13 at 8 a.m. and a GCS 10 at 10 a.m.
That's a clear warning bell.
Exactly. Objective evidence of deterioration. It tells you something bad is happening now and you need to act fast. It's like the universal language for neurostatus.
So as that GCS potentially drops and brain function worsens, we look for signs moving downwards through the brain, this rostral to caudal thing.
Precisely. Pressure or injury starting high in the cerebrum and affecting structures lower down towards the brainstem. And we see specific reflex changes along the way.
What are the big ones to watch?
Pupils, number one. How do they react to light?
Okay.
Are they brisk?
Yeah.
Sluggish? Or are they fixed and dilated? A non-reactive blown pupil is a very, very bad sign.
Bilateral versus unilateral makes a difference.
Big difference. Bilateral, fixed, and dilated. You're thinking serious brainstem damage. But if it's just one pupil, unilateral,
yeah,
that often points to compression. Maybe pressure building on one side is squishing the optic nerve or the oculomotor nerve pathway. It can be an early warning of herniation.
We also check eye movements, right, in someone who's comatose. The doll's head maneuver.
The oculocephalic reflex, yeah. If you turn the head side to side, normally the eyes should move conjugately, like together to the opposite side, like a doll's eyes. If they do that, it tells you the connection through the pons level of the brainstem is likely intact. If the eyes just stay fixed, staring straight ahead as you move the head, that's bad. Reflex is absent.
And then there's the posturing, those involuntary movements.
Yeah, grim signs.
Yeah.
Decorticate and decerebrate. They tell you where the damage likely is.
Decorticate is flexor, arms pulled in.
Right. Arms flexed tight to the chest, wrists and fingers flexed, legs extended. Think towards the core. That usually means lesions are higher up, cerebral hemispheres, internal capsule.
But decerebrate, that's worse.
Generally indicates a worse prognosis. Yes, it's the extensor response. Arms rigid, straight out, palms turned away, legs stiffly extended.
And that points lower down.
Midbrain, upper brain stem involvement. The injury has definitely progressed downwards. When you see decerebrate posturing, things are critical.
And the final stage of this downward spiral involves breathing.
Absolutely. As the injury hits the lowest centers, respiration changes. You might see Cheyne-Stokes breathing first.
That waxing and waning pattern with pauses.
Exactly. Then it can progress to central neurogenic hyperventilation, just super fast, deep breathing, like over 40 breaths a minute, completely unregulated.
And the end of the line.
Ataxic breathing, totally irregular, unpredictable pattern. Then empia, no breathing at all. That means the medulla, the final control center, is failing.
This whole progression leads us to the ultimate end states, brain death being one.
Irreversible loss of all brain function, including the brainstem. Critically, you have to confirm apnea, no attempt to breathe, even when CO2 levels get really high, like a PCO2 of 60 or more.
And how is that different from a persistent vegetative state, PVS?
In PVS, the higher cognitive functions, awareness, are gone, lost completely. But the brainstem is still working.
So they have basic functions.
Reflexes, sleep-wake cycles, maybe spontaneous eye-opening, breathing, the vegetative functions remain. But there's no awareness, no purposeful interaction. And for the diagnosis, that state has to last at least a month.
Okay, that's a really important distinction. Let's shift from the signs to the mechanisms. How does this damage actually happen? Increased intracranial pressure, ICP, seems central.
It often is, and you have to start with the Monroe-Kelly hypothesis.
The skull box analogy.
Kind of. The skull's rigid, volume is fixed inside. That volume is mostly brain tissue, about 80%, then maybe 10% blood and 10% CSF.
Right.
If one component increases, say you have a bleed, adding blood volume.
Something else has to decrease to make room.
Exactly. The body compensates. It pushes CSF out into the spinal canal. It compresses the veins to squeeze blood out. Initially, it handles small volume changes pretty well.
That's high compliance. Adding volume doesn't spike the pressure much.
Correct. But that compensation has limits.
Yeah.
Once you've squeezed out all the CSF and compressed the veins as much as possible, you're out of tricks.
Compliance drops off a cliff.
Right. Then even a tiny bit more volume, a little more swelling, a little more blood, makes the ICP skyrocket.
And that's dangerous because it affects blood flow to the brain, the CPP.
Cerebral perfusion pressure, critically important. CPP is your mean arterial pressure, MAP, minus your ICP.
MAP minus ICP.
If ICP climbs too high, it starts to cancel out your MAP. CPP falls. If it drops below about 40 millimeter Hg, the brain isn't getting enough blood. Ischemia starts.
You said earlier that decreased LOC is the earliest sign of rising ICP.
It often is, yeah. Subtle confusion, restlessness.
But there's a classic late sign too. The Cushing triad. That means things are really bad.
Oh, yeah. Cushing's triad is an ominous late sign. It's the brainstem's last-ditch effort. You see three things. Hypertension blood pressure goes way up.
Okay.
Bradycardia heart rate paradoxically slows down.
Weird. Why slow?
It's a reflex response to the sudden hypertension. And the third part is a widened pulse pressure. The gap between systolic and diastolic pressure increases.
So high BP, low heart rate, wide pulse pressure, that's the triad.
That's it. It means the brainstem is ischemic and trying desperately to force blood flow past that high ICP.
If ICP isn't controlled, the brain can actually shift or squeeze out of place. Herniation.
Yes. Displacement of brain tissue. The one we really need to highlight is uncal herniation.
Okay, what happens there?
The unicus, which is part of the medial temporal lobe, gets forced down under the tentorium cerebelli, that membrane separating cerebrum from cerebellum.
And as it squeezes down?
It traps cranial nerves, the third, the oculomotor nerve.
Ah, leading to that unilateral pupil dilation we mentioned.
Exactly. The ipsilateral same side, blown pupil. That's the classic early warning sign of uncal herniation. It can also cause weird signs like weakness on the same side as the herniation due to pressure on the opposite brainstem pathways, a false localizing sign.
Wow, that's clinically tricky but vital to know. Okay, let's talk swelling itself. Cerebral edema. Two main types.
Vasogenic and cytotoxic.
Vasogenic is.
Think leaky vessels. The blood-brain barrier breaks down maybe from a tumor, infection, inflammation. Fluid and proteins leak out of the vessels into the extracellular space, mostly affects white matter.
Okay, leakage outside the cells and cytotoxic.
That's cell swelling. Fluid rushes into the neurons and glial cells themselves. Intracellular edema.
What causes that?
Usually severe ischemia or maybe very low sodium levels. The problem is the cell's energy fails, particularly the sodium-potassium pump.
The pump that keeps sodium out and potassium in.
Right. When it fails from lack of energy, sodium rushes in, water follows, and the cell swells up like a balloon.
And that pump failure links directly to hypoxic and ischemic injury.
Absolutely. Quick distinction first. Hypoxia is low oxygen, but blood flow is still okay. Ischemia is a low blood flow.
Which is worse?
Ischemia, much worse, because you lose oxygen and glucose delivery, and you can't clear out waste products like lactic acid. It's a triple whammy.
How quickly does damage happen in, say, global ischemia like cardiac arrest?
Fast. ATP, the cell's energy currency, is basically gone in about 4 or 5 minutes.
Wow.
Once ATP is gone, that sodium-potassium pump fails, sodium floods in, calcium floods in, and that calcium is the real killer.
The calcium leads to excitotoxicity.
Yes, this is a huge pathway. During ischemia, there's a massive release of the neurotransmitter glutamate.
The main excitatory one.
The main one. Too much glutamate floating around forces open specific channels on the neuron surface, particularly the NMDA receptor channel.
Okay.
And that channel lets in a flood of calcium. It's called the calcium cascade.
And that cascade does what?
It activates all sorts of destructive enzymes inside the cell proteases. Lipases basically digests the cell from within, leads to cell death.
And this hits certain brain cells harder than others. You mentioned complex neurons.
Exactly. Those neurons involved in memory and higher cognition, places like the hippocampus, they have a very high density of these NMDA receptors.
So they're more vulnerable to this glutamate flood.
Precisely. It explains why, after a global ischemic event, even if someone recovers basic function, they often have persistent problems with memory, concentration, that higher level stuff. Selective vulnerability.
Makes sense. Okay, let's pivot to section 3, cerebrovascular disease, stroke.
The acute manifestation of a lot of these processes.
We have 2 main blood supplies, right? Anterior and posterior.
Yep. Anterior comes off the internal carotids, feeds the front and middle parts of the brain. Posterior comes from the vertebral arteries, joining to form the basilar artery, feeds the back parts, brainstem, cerebellum.
And they connect.
At the base of the brain, yeah. The circle of Willis. It's a crucial ring of arteries connecting the anterior and posterior systems.
Provides backup flow, collateral circulation.
Exactly. If one major vessel gets blocked, the circle can sometimes reroute blood flow to prevent or limit the damage. It's a fantastic bit of natural engineering.
And flow is regulated, autoregulation.
Tightly regulated. The brain maintains pretty constant blood flow even if your systemic blood pressure changes. Within a certain range, usually MAP, between 60 and 140 millimeter Hg.
What tells the vessels to open or close?
Mainly metabolic factors. The big ones are increased CO2 levels and increased acidity or hydrogen ions. When those go up, brain vessels dilate to wash them out.
Okay, stroke types. Most are ischemic.
About 87%, yeah. Caused by a blockage. It could be a clot forming right there, thrombosis, or a clot traveling from somewhere else, an embolus often from the heart, cardioembolic.
And within that ischemic area, there's the core and the penumbra.
Crucial concept. The core is the central area where blood flow is so low the cells are already dead or dying rapidly. Irreversible damage.
But the penumbra?
That's the zone around the core. Blood flow is reduced, cells are struggling, electrically silent maybe, but they're not dead yet. They're stunned, but potentially salvageable.
So all acute stroke treatment is basically a race to save the penumbra.
That's the entire goal. Restore blood flow quickly enough to rescue those cells before they transition into the dead core. Time is brain.
Which makes TIA's, transient ischemic attacks, so important.
Absolutely. A TIA is like a stroke symptom that resolves completely, usually within an hour, without causing permanent infarction. But it's a massive warning.
How big a warning?
Porth notes that 10–15% of people who have a TIA will have a major stroke within 3 months. It's a critical window for intervention and prevention.
Okay, then there's hemorrhagic stroke. Less common, but more deadly.
About 13%.
Yeah.
Caused by a ruptured blood vessel bleeding into the brain tissue or surrounding spaces. Higher fatality rate, yeah.
And a specific type is aneurysmal subarachnoid hemorrhage, SAH.
Right. Usually a rupture of a Barry aneurysm, a little outpouching on an artery, often found at junctions in that circle of Willis.
The classic symptom is?
The worst headache of my life.
Yeah.
Sudden, incredibly severe headache, often with nausea, vomiting, maybe loss of consciousness.
After the bleed is maybe controlled, what are the big worries with SAH?
2 major complications. Rebleeding, especially in the first 24 hours, and vasospasm.
Vasospasm, the arteries clamping down.
Yeah, the cerebral arteries constrict, usually peaking around 7 days after the initial bleed. This can cause delayed ischemia, a secondary stroke, even if the aneurysm is secured. It's a major management challenge.
Clinically, for any stroke, we look for sudden, focal, one-sided symptoms, right? Fast mnemonic face, arms, speech, time.
That's the public health message, yeah. Sudden facial droop, arm weakness, speech difficulty, call 911 immediately.
Let's clarify speech problems. Dysarthria versus aphasia.
Good distinction. Dysarthria is a motor speech problem. The mechanics of articulation are messed up, slurred speech, difficulty forming words clearly, but language itself is intact.
Whereas aphasia is a language problem.
Exactly. Trouble with comprehension or expression of language. And we split that further. Broca's aphasia.
That's expressive, non-fluent.
Right. They understand pretty well. They know what they want to say, but they struggle immensely to get the words out. Short, effortful sentences. Very frustrating for them.
And Brenniges.
That's receptive aphasia. Fluent. They can speak easily, sometimes excessively word salad, but the content doesn't make sense, and their comprehension of spoken and written language is severely impaired. They often seem unaware of their deficit.
Diagnosis. First step in the ER for suspected stroke.
CT scan. Immediately. Non-contrast head CT.
Why so critical?
You have to rule out hemorrhage. Because the main treatment for ischemic stroke is the clot-busting drug TPA, tissue plasminogen activator.
And you absolutely cannot give TPA if there's bleeding.
Correct. It would make the bleeding catastrophic. So CT first to see if it's ischemic, no blood, or hemorrhagic blood present.
And if it is ischemic, there's that time window for TPA.
A very tight window. Traditionally 3 hours from symptom onset, now extended to 4.5 hours for some eligible patients, but the earlier the better. Every minute counts for saving that penumbra.
Okay, quick run through the last section. Infections, tumors, seizures, CNS infections, meningitis.
Inflammation of the meninges, the brain coverings, and the CSF. Bacterial is the dangerous one.
How does the CSF look?
Cloudy, purulent, high protein, high white cells, and crucially low glucose because the bacteria eat it. Clinically, look for fever, headache, stiff neck, neutral rigidity, and maybe Kernig's or Brudzinski's signs.
And viral meningitis.
Usually less severe, self-limiting. CSF shows lymphocytes. Protein might be mildly up, but glucose is typically normal.
Then there's encephalitis.
That's infection of the brain tissue itself, the parenchyma. Often viral herpes simplex, West Nile virus, things like that.
Symptoms are more severe.
Generally, yes. Lethargy, confusion, seizures, focal neurological deficits like paralysis can be very serious.
Brain tumors. Primary versus metastatic.
Primary start in the brain. Can be from glial cells, astrocytomas, including the aggressive glioblastoma multiform, the most common primary adult type, or from non-brain tissues like meninges, meningiomas, often benign. Metastatic means cancer spread from somewhere else in the body.
How do they present?
2 main ways. Focal signs, depending on where the tumor is pressing, causing weakness, sensory changes, speech problems, and signs of increased ICP headache, often worse in morning, worse with coughing, vomiting, mental status changes, papilledema, swelling of the optic disc.
Finally, seizure disorders. Seizure versus epilepsy.
A seizure is a single event, a sudden, abnormal electrical discharge in the brain. Epilepsy is the chronic condition recurrent, unprovoked seizures.
Classification. Focal versus generalized.
Focal seizures start in one area, one hemisphere. Generalized seizures seem to involve both hemispheres right from the start.
And focal can be aware or impaired awareness.
Right. Focal aware used to be called simple partial. Consciousness is preserved. Might be motor twitching, sensory symptoms like tingling or flashing lights. An aura is actually a focal aware seizure.
Ah, okay. And focal impaired awareness.
Used to be complex partial. Consciousness is affected. Often starts in the temporal lobe. Characterized by automatisms, repetitive behaviors like lip smacking, picking at clothes, and followed by a period of confusion, the postictal state.
Generalized seizures, the main one.
Tonic-clonic, formerly grand mal, is the most recognized major motor seizure. Sudden loss of consciousness, body stiffens, tonic phase, then rhythmic jerking, clonic phase.
Also, atonic seizures, drop attacks.
Yeah, sudden loss of all muscle tone. Person just collapses. Very dangerous for injury.
And the emergency situation. Status epilepticus. Seizures that last too long, typically 5 minutes, or occur back-to-back without the person recovering consciousness in between. Medical emergency needs immediate treatment to stop the seizure activity. So we see how it all kind of loops back, whether it's trauma or stroke or a tumor.
Yeah.
They can all lead to ischemia or direct cell injury. That causes excitotoxicity, leads to edema.
Which raises the ICP?
Driving that clinical decline, the altered LOC, the posturing, the respiratory changes we started with. It's all interconnected. One process fuels the next.
It really paints a picture of how these cascades work.
Okay.
Final thought for our listeners. Something to chew on.
Well, think about those time windows again. TPA within 3 or 4.5 hours. The fact that ATP is gone in under 5 minutes in global ischemia.
Yeah.
It really underscores that understanding the speed of these pathophysiological processes is just as critical as understanding the mechanisms themselves. Functional survival often comes down to how quickly we can intervene based on knowing how fast neurons die. It's not just what happens, but how fast.
That's a powerful point. Respect the clock. Absolutely.
Well, thank you for joining us on this deep dive into brain pathophysiology. We really hope this breakdown helps connect the dots for you.
Hope it clarified things and gives you confidence in understanding these critical concepts.
We look forward to diving deeper with you again next time. Thank you from the whole deep dive team.